Okay, everybody, welcome back to the pre-hospital case study of Grandeur, and this is going to be our lesson number 2. A couple months ago, I posted our first lesson back since the termination a couple years ago, so we're really excited to be presenting again. It's May 15th, 2014, and today we're talking about wide complex tachycardia and what will help you be more comfortable with saying this is or is not V-Tach. So we're going to go over 3 cases, all of which turn out in the end to be V-Tach. So we're going to let you guys take a look at them and some of the factors that helped us make an otherwise potentially difficult case not as hard. So without anything further, we're going to look over the next 3 cases. So number 1, we have a 54-year-old male, and he's been weak for a couple of days. And what's interesting is we had to break into his apartment door, and he was too weak to get off the couch and come open the door, even though it was just a couple feet away. And he didn't want us really checking him out in his apartment. And the reason is he's been so weak for 2 days, they felt like he would pass out if he got up off the couch. So everything that was close enough to him that he could fill with urine, he filled with urine. A cereal bowl, a vase, cups and glasses, pop can, that sort of thing. So everything around him had urine in it, and he was very uncomfortable. He felt very embarrassed that he's been doing that, and he's been hoping that he would feel better. So he was avoiding calling the ambulance for about 2 days. So finally, he couldn't get up off the couch, and he decided to dial 911. So after we forced the door, he decided he wanted to come down to the ambulance for us to check him out. And he wasn't able to make it all the way down the steps. We had offered to carry him, and he refused. So he actually had to scoot down the steps on his rear end down to the bottom where we had the stretcher. And none of this was going towards protocol. We did not feel comfortable with it, but sometimes the patient has rights. They get to make their own decisions, even if they're a bad one. And of course, we get him into the ambulance, and he's much sicker than he appeared in his dark apartment. Heart rate was 200. We could not obtain a BP. In fact, his BP was so low that when I finally got an IV in his hand, 20 gauge in the hand, which he had no vascular access, we were about to do an intraosseous when I got this 20 gauge in his hand. And when we took the needle and the hub apart, and I let my finger up to make sure blood was coming out still, because like I said, he was very hard access, the blood actually went to go back inside of him. He was so clamped down peripherally that the blood was like a vacuum going back inside of him towards his core. But of course, we got the IV. Saturation wasn't the greatest, but we couldn't get a good waveform because his peripheral circulation was so bad. And he was a little tachypnic, and he didn't really have any cardiac history. So as my partner puts him on the heart monitor, we find this rhythm. So just a couple things immediately jump out at you if you just had these strips. One, clearly you can tell that we cardioverted the poor man. And that's because he had no blood pressure, was complaining of feeling like he was going to die, and was having difficulty breathing. So we cardioverted him pretty hastily. But furthermore, if you look up here, there's some irregularity to this, and even over here, which sometimes that leads people to believe that maybe this is an AFib, or usually an AFib with irregularity at a very fast rate. And the rate is very fast, about 200 beats a minute, which is unusual for a V-Tach. But after doing some research, there's not a cap on the upper rate of V-Tach. A lot of people suggest that the normal V-Tach rates are 160 or 170 or higher. And I guess that's the case. But like I said, I couldn't find any good information on when does it unlikely be V-Tach because of a rate. There's almost no literature on that. But if you look down here in the second strip, you can see it evened out very well. And so it actually is very regular there just before the cardioversion. So I don't know if this top was movement or just slight irregularities, which is normal variation for anybody. But we'll talk some other things on these strips here. So what are some hints for or against V-Tach. So obviously that top one, pretty regular. We focused in a little closer. Another thing we want to talk about is this Josephson sign. I want you to just keep this in your mind, and we're going to go over that in a later case. We're not going to talk about that right now, but this case was actually called that they said they saw the Josephson's sign, but it is not there. So that's a really hard name to say. Uh, the Josephson sign is not on this case. We'll talk about that later. Here you can see what's called a fusion beat, which is where the sinus node tries, excuse me, the sinus node tries really hard to take over. So you can see this beat is a little more narrow, has a different morphology, and that's basically when the sinus node is trying to take over the rhythm and break through this V-Tach. And if there were any subsequent sinus beats after that, those are called capture beats until the V-Tach resumes. However, clearly, as you can tell, this person's sinus node failed. It was a very feeble attempt at becoming a capture beat, and the patient reverted right back in to the wide complex tachycardia. So if you look at the 12 lead, the 12 lead is wide. It shows clearly a wide QRS and very regular looking on the 12 lead. So those are all factors in favor of ventricular tachycardia. The end result was the patient turned out to be hypokalemic. He went to the electrophysiology lab where they confirmed that he was in V-Tach. He was given a implanted pacemaker defibrillator, and he was discharged to home on day 4 with no problems. What we learned from this is the most simple, straightforward case of V-Tach of the 3. And I wanted to give you this one just because it was easy. This is a wide, regular, fast. You have to think that this is ventricular tachycardia until proven otherwise. If you want to diagnose people with SVT or AFib with aberrant conduction, you could potentially kill someone if it's a person who has ventricular tachycardia. Whereas otherwise, if the person is in ventricular tachycardia and you treat them, if they're in SVT or AFib with aberrant conduction, but you treat them for ventricular tachycardia, it's unlikely that you're going to do any harm with those medications or treatment modalities. But some of the medications that you would give for AFib or SVT could be fatal if the person's suffering a condition that's putting them in the ventricular tachycardia. Also, fusion beats are very common in V-Tach. So if you see a wide complex tachycardia that's pretty regular and every once in a while has a fusion beat and some capture beats, then you should assume that this person is in V-Tach until you can prove otherwise. So that's what we boil it down to from case number 1. Like I said, that one was very easy. So we move on to case number 2. This man's a prisoner in the jail here in Allegheny County. He's 35 years old, and he complains of dizziness and palpitations. Once before, he had the same symptoms, and they resolved by themselves after about 20 minutes, and he never sought help for it. So he only has a history of bipolar disorder, no cardiac, appropriate medications. When the ambulance crew arrived, this is by one of my really good friends and roommate, Rich. When his ambulance arrived at the patient, his heart rate was almost 300, which is astounding. Good blood pressure, though, which oftentimes is misleading. It brings people to believe that the person may be in SVT or AFib because their blood pressure is good, but that is a misnomer. And his oxygen level on high flow oxygen non-rebreather mask was 98%. So they actually gave him 6 milligrams of adenosine as a diagnostic challenge, and nothing happened. They repeated it, 12 milligrams of adenosine, and again, nothing happened. So they actually got on the radio and started a medical command consult to potentially cardiovert the patient, and it broke spontaneously. Now, unfortunately, I don't have the rhythm strip where it broke, but there was no slowing down. I saw it with my own eyes. There's no slowing down. There's no weird AV conduction block. It literally mid-wide complex beat converts into like a fusion beat and then is in a normal sinus rhythm from there on. And again, that happened during the medical command consult a couple of minutes after you give the adenosine. Remember, adenosine only has a really short half-life, so it's unlikely that adenosine would be effective after 2, 3, 4, or 5 minutes. So they put the heart monitor on him, and you find this very, very rapid. You can see that the heart rate is almost 300, 282. But remember, like we talked about in the last case, that's not always a proof of anything. So he's definitely got a wider complex, and he is tachycardic. And that is where we're going to stop with that until we look at some of the other things here. So we zoom in here so we get some hints going. So the first one is a steeple sign. Now, steeple sign is pretty highly indicative of ventricular tachycardic. And what that is when the QRS goes up and straight down, like a church steeple. Just goes up and it goes down. Goes up and it goes down. Whereas when you have some form of notching or rabbit ears, that can be indicative of some type of conduction delay. Okay? And the next thing you notice is there is evidence of AV dissociation, which is way more common in ventricular tachycardia and is actually a good indicator, highly specific for V-Tach, when you have evidence of P waves that are disassociated from the QRSs. And here you have a set of a couple P waves which you can tell are clearly out of place and does not fit in with the rest of the QRS complexes. And there might even be a couple more down there, but these are the most clear. So another hint that we have is if you look here, something we talked about in the last case, you can kind of see it. I'll give you a second to think about it, and it's not too hard to figure out. There's one main irregularity, and it is the attempted fusion beat, which does not capture. So there's no capture beats following this fusion beat, and that is important to note because if you look here, clearly this QRS is much more narrow than the other QRSs. Also, there's clearly a sinus beat. So the sinus node is really trying hard to take over this aberrant rhythm, and unfortunately, it fails. The patient just continues in ventricular tachycardia. Another thing that you notice down at the bottom are some more examples of AV disassociation. You have a lot of regular looking QRSs, but every once in a while you get that weird notching, and oftentimes that weird notching is actually the P wave, and that is the AV disassociation while the patient's ventricles are beating like crazy and the atria are just going along like nothing's happening. So here's the 12 lead for case number 2. You can see that the QRS is wide, but it's also extremely fast. And the monitor is calling it a left bundle branch block, which in this case it is way too hard to discern. And as you can see, you have the steeple sign in multiple leads. You have it over here, straight up and down, no notching. You have it right here, even though it's buried under the V3 is buried a little bit under V2, but straight up and down, no notching. And all the leads over here, you can see that straight up and down, no notching steeple sign. Again, highly specific for ventricular tachycardia. So after the patient broke spontaneously, you can see the drastic difference in conduction for the pre and the post 12 lead. So if you were to get these two 12 leads, one's a pre, one's a post, and the person, kind of looks like they might have a left bundle branch block here, but you can't really tell because it's too fast. Then you go here and they have a clear left bundle branch block, then it is potential that person was just in an aberrant SVT or even a aberrant fast sinus tachycardia. However, here you can clearly see that the morphologies of the QRSs are completely different in most of the leads compared to the 12 lead where the patient's in the wide complex tachycardia. So what are we going to take home from case number 2? I want to talk a little bit about adenosine sensitivity. ACLS describes this as a safe and effective practice, but the studies that claim is based on are not I would say not reliable. The methodology they used was poor. They were kind of in a circular argument with themselves where they counted on their procedure to make the diagnosis and then the diagnosis to make the conclusions. So I would say that adenosine sensitive, diagnostic adenosine challenges are not the most effective for differentiating between V-Tach and SVT. As you would note, 10% of V-Tach is adenosine sensitive. A couple of Japanese studies proved that. And you have to be skeptical in this case because the patient received adenosine and it didn't break right away. But patients who are on V-Tach and are adenosine sensitive usually have no cardiac history and are younger people, 30, 40, 50, with some other problem going on. And those are the people you'd be more likely to believe were in SVT with aberrant conduction than a person that would be in V-Tach because they have no history. Steeple sign, the AV dissociation is a recurring theme, and the drastically different QRS morphologies, which we'll talk about again in case number 3. So this case is actually a rather interesting one. 20-year-old male has palpitations, chest pain, and diaphoresis. Heart rate's about 120. His blood pressure is 119/88, and his saturation 99%. And we're not going to talk too much about his history because I'd like you to base your conclusions on the EKGs, and then we'll talk about his history afterwards. So this is his initial rhythm, and it clearly is bizarre. And when someone says the word bizarre to you, there's two things that should always come into mind. Either hyperkalemia or some type of ventricular dysrhythmia are usually associated with the word bizarre. So you put them on the monitor, you take a look here, and you clearly see that he's slightly tachycardic. He is in a wide complex, but the morphologies of this thing is all over the place, very hard to see. And if you note carefully up here, because I know you're gonna be thinking about, there are pacer spikes there, so that might help you out a little bit with the diagnosis. But for now, pretend those aren't there. You didn't see them, and you don't know that the person has an AICD. So some hints for diagnosing this person. We zoomed in pretty closely so you could see. So obviously the person's QRS is extremely wide. Okay. Now this is a legitimate Josephson sign, and a Josephson sign is a notching that occurs before the terminal end of the S wave. So whenever you have a V-Tach, excuse my drawing, yeah, we'll start over here. It's just could be slight, could be more pronounced. So whenever you have on, as you're approaching the terminal end of the S wave, this notch, it's called Josephson sign. And this is highly, highly specific for ventricular tachycardia. And the reason that in the previous EKG, where someone said the person had Josephson sign and they were incorrect, was they had actually diagnosed it on the upslope. And that is really just the J point for that person. So they had misdiagnosed it. Josephson sign occurs on the downslope before the terminal end of the S wave is a little notch, which is highly specific for ventricular tachycardia. Also, you can see here AV dissociation, which is actually what's causing the extreme difference in the morphologies in all of these QRSs. Because as you'll see in the later EKG, these little bumps are gigantic. And you would just expect that not to be the P waves, but in his post-treatment EKG, you'll get to see exactly what we're talking about. So here's the 12 lead of the person with the wide complex tachycardia. Even the monitor, which is kind of funny, is giving you the rate is slow enough here that it's telling you there's AV dissociation. And you can see that the person has potentially a right axis deviation, some deep S waves, notched QRSs, and tachycardic, but clearly not a sinus tachycardia. So what rhythm is it? So we actually gave the patient amiodarone, and we knew what the patient was in for sure. So there was no doubt in our minds that this person was in ventricular tachycardia, even though the rate was only 120, which we'll talk about. But as you can see here, we'll compare the pre and post 12 lead EKGs. And some of the things you want to note is that things changed so much before and after treatment that it had to be V-Tach, right? So first of all, look at the QRS morphology. It's extremely different. So if the computer would have diagnosed this as a left bundle or something like that, you can clearly see the difference in QRS morphologies. And amiodarone does not affect the bundle branches. It will not correct a bundle branch block. So if you just look at the two leads I picked out that showed really good examples, huge negative deflections with potentially that Josephson sign in the top EKG in lead 1, and a kind of biphasic QRS with an inverted T in lead 1 in the bottom EKG. In V4, nothing but a huge S wave and a tall T, and in V4 in the second EKG, you clearly have a pronounced P wave, a biphasic QRS, and an inverted T wave. So clearly this person appears to have been in ventricular tachycardia. The other thing is you can tell by the P wave morphologies in, like we had talked about before, if you're looking lead AVF, the P waves are gigantic. The patient had biatrial enlargement as per uh, the EKG machine. But if you track out the P's, especially in leads 2, AVF, V3, V5, V6, V4, where you have these gigantic P waves, that is what's causing those QRS distortions all over here. And if I can hit my pen button here, you can see there's one for sure. Here's one. Let's take a peek here. That's about up. Here's one. There. You can see this one. This one is taller and has a little notch in it compared to the ones before it. So you can easily see that those P waves are marching to their beat of their own drummer, so to speak, while the patient's in V-Tach. Now we have to figure out why this person's in V-Tach at a rate of only 120, right? And so we had talked about leaving out the history. The additional history for this patient is that he has significant cardiac history, including congenital defects, which I was not on this call, so I don't have the specifics for me. I was sent to me by one of my really good friends and my partner at Pittsburgh Medic 3, Jeff, and he and our other partner were on this call. He has a history of multiple V-Tachs, which in the past were very fast, uncomfortable, and made the patient feel like he would die. And he underwent 2 cardiac ablations to deter the ventricular tachycardia, and he also had an AICD placed just to be safe, but it only fires when when this young man was in V-Tach at a very high rate. And he doesn't reach those high rates anymore because of the ablations. But nonetheless, the patient this is his first episode of V-Tach since his second ablation. So he says he feels the same as the prior episodes of V-Tach. He knew he was in V-Tach. That's why we were so easily convinced, even though that could have been a difficult EKG. We were very easily convinced that the patient was in V-Tach because he knows when he's in V-Tach, he feels the same way. It's just not as severe, and you could probably attribute that to the ablation and the rate not being as high. So what are we going to take home from case number 3? Pay attention to those drastically different QRS morphologies. Look for that AV dissociation. The history is very important, and it's actually found that patients that have no cardiac problems, excuse me, the patient has non-SVT related cardiac history. So the patient has no history of SVT, but he is in a wide complex tachycardia. That patient is 85% of the time diagnosed with ventricular tachycardia and treated as such. So that leaves only a few percentage points, down to 15% of people with no SVT but has a cardiac history that are in wide complex tachycardia are actually in V-Tach. Things to take home: Pay attention to the history, look for AVD, fusion and capture beats, right axis deviation, drastically different QRS complexes. Watch out for that sneaky adenosine challenge, diagnostic challenge that people talk about. And just remember, if it's wide complex tachycardia, assume it's VT until proven otherwise. And I appreciate you guys for taking your time for this quick lesson. I wanted to share those EKGs with you. I know it wasn't as clever or as amusing as in the past, but I wanted to get those out to you since I haven't been able to post a class in a couple of months. Remember, send me all of your EKGs and cases that are interesting. Email it to ekgs4james@gmail.com. I forgot to put that on the end, so I apologize. Send me an email if you have any questions. Send me your EKGs and pay attention for the next class. Thanks a lot, and thanks for stopping by.